Hi, and thank you for joining our educational webinar with Dr. Luriel Smith-Harrison. Today, we will address the many factors affecting men's reproductive health and discuss treatment options for infertility troubles. I am Leslie Hartz, and I'm a member of the VCU Health marketing team. Before we begin the presentation, I would like to note that we will hold all questions until the end. Please feel free to drop any questions you may have in the Facebook comments section throughout the event, and we will address them during the Q&A portion. An assistant professor of surgery at VCU Medical Center, Dr. Smith-Harrison treats conditions such as low sperm count or sperm that move inappropriately, erectile dysfunction, and infertility troubles caused by hormone imbalances or spinal or nervous system injuries. He also performs vasectomy and reverse vasectomy procedures. Dr. Smith-Harrison works alongside a team of urologists and clinical staff focused solely on men's health and improving each man's quality of life. Thank you again, Dr. Smith-Harrison, for joining us today. I'll now turn over the show to you.
Great. Awesome. Thanks, Leslie. Thanks for everybody for joining. Usually we do this in person, but obviously we can't at this moment, but I really appreciate y'all coming here. So to start, just some basic disclosures. First off, not sponsored by any companies or private entities. I am in a research partnership with a small company called Contraline, which works or is working on developing a male contraceptive. But it's neither here nor there, so we'll get to things. Leslie kind of went through this already, but just kind of who I am. Again, a professor here in the urology department at VCU. I'm the main guy for male infertility concerns here at VCU, so anything that funnels into the system, I see those patients. I do work closely with the reproductive endocrinologists here who provide fertility care for the female side, so literally in the same clinic, because obviously fertility is a two-person, is a partner issue. Fellowship trained specifically in male infertility and microsurgery, which allows me to do these specific surgeries. One thing I'm not a hormone expert. For patients where hormones start to become a little more complex, I tend to refer those patients to endocrine, and we work through the fertility concerns as a team. Also Richmond local. So made it back. So what are we going to talk about today? We'll just kind of start with basically facts about male fertility, kind of who is affected, statistics, some basic anatomy and physiology. We won't be going into the birds and bees talk, but kind of more the nitty gritty fertility focused items. From there, we'll kind of shoot to who should be screened, who is it reasonable to come in with concerns about fertility and whatnot. Moving from that, we'll go into what is the workup, kind of what are the steps, what should you expect should you come in to be seen for fertility concerns. And then we'll talk about possible modes of intervention should we need to do something. Kind of one thing we'll also address towards the end is some more recent data and concerns with kind of the trajectory of sperm counts and infertility in kind of a modern world with chemicals, pesticides, et cetera, which has kind of come up in the news more recently. So we'll kind of finish off with that. All right, so some facts about male fertility. So in terms of fertility, in terms of concerns, about 10% of couples are affected. So that obviously can be variable degrees. Either it took them longer to get pregnant than they wanted, or they needed procedures, surgeries, interventions, and that's either male or female side. Specifically, male factor subfertility, just as a caveat, I like to say, or I'll interchange subfertility with infertility. Most guys aren't infertile. We just might have to do some work to get there. So that's why I like to use subfertility. But that can be involved in about 50% of these cases. 20% of the time, it's strictly the male that's involved, or we call it male factor. About 30% of the time, it involves both partners. And as somebody who focuses on kind of andrology, or the study and taking care of men's health, we also have to look at fertility in a bigger context. So if you look at big data, there's about a 2 to 20% increase in risk of testicular cancer if you have some level of subfertility. And it's thought to be kind of, obviously, the testis isn't working as well as it should in subfertility. So there's a thought that there's a base problem with the testis itself, which lends itself to a higher risk of cancer. There's also some data showing that at baseline there's a twofold increase in all-cause mortality or death if somebody has a history of infertility. Again, it's not a direct cause or correlation, but if you have ingrained genetic issues, that can affect both your overall health and your fertility. You also have to kind of think about fertility as kind of the canary in the coal mine. If your health isn't so great or your body's not doing so well and it's trying to have to ration or kind of pick where it wants to send energy, fertility is kind of the first thing that can shut down without affecting all the other organ systems. So if you can't go at 100%, then that's the first thing that your body's going to throttle back on is fertility and testis function. So that's kind of the big picture. So anatomy and physiology. So we're just kind of going to go through kind of the basic anatomic structures that you need to be a fertile gentleman. So unlike what my buddies said in middle school, the scrotum is not where you store your pee, store your urine. It's where your testicles, your testes are. So obviously, and hopefully you can see a little cursor, that's the main organ that allows fertility to happen. So the testis is actually basically this tunica, which is a thick capsule that encloses the seminiferous tubules. And this is obviously a cartoon kind of depicting that. Think about it like a bowl full of spaghetti, just all of these little tubules all packed together in no real coherent or structured fashion, just kind of packed in to the testis. But each of these tubules has some pretty important kind of cell populations. So obviously the first thing that we have are the cells that will become sperm. So they don't start that way, but they'll become that kind of over a series of progression of development and growth. With that, you have some other cells that we call Sertoli cells. These are called kind of the nursemaid cells. So these help these early sperm cells develop into a fully mature sperm. So without those, they can't really get to where they need to be. You also have what we call Leydig cells kind of packed in here. They're not on the cartoon, but they're kind of interspersed throughout the testis. And these are the cells that are responsible for testosterone production inside the testicle. Without that concentrated testosterone inside the testicle, you're not going to get the progression of spermatids and sperm into that final mature form. So after they go through that, and actually making sperm takes about 74 days, which is actually important in terms of management, so about a little less than 3 months. After they make it through the development to a spermatid, they make it to the epididymis, a little gland on the back of the testicle. I say it's kind of like high school for sperm. It's where they go to learn to swim before they go out into the big world. This, unlike the testis, is a single tubule that's exceedingly small, packed into basically the size of about 1.5 inches. If you stretch that little tube out, again, it's about 1.5 inches. If you stretched it out completely in a line, it's about 20 to 30 feet long, just to give you an idea of how thin that tube is. But extremely important in terms of development of the sperm and allowing it to do its job. From there, we go to the vas deferens. So this is a little tube. We'll hop up here. That takes sperm up and around behind the bladder to the urethra. This is the site where we do vasectomies. So if you block this tube, sperm can't get out. You have contraception. Once you hit the prostate gland, you also have the seminal vesicles, the prostate gland. These actually create the majority of your ejaculate, of what comes out when you ejaculate or have an orgasm. Don't come from the testis. Actually, they come from the seminal vesicles in the prostate gland. So everything meets up at the urethra where things come out. So a quick little anatomy lesson there. This is important because when we're doing a workup for fertility, we need to think about anatomic concerns. So one thing we find are varicoceles. So these are dilated veins that take blood away from the testicle, which you can kind of see right here. Varicoceles are exceedingly common. About 20% of men have them, but you see them even more so in 40% of subfertile men. We don't intervene on all varicoceles. We don't operate on 20% of guys, but it is pretty common. And what we believe happens is basically it affects the testicular microenvironment and makes it harder for the testis to function. So the whole reason that your testes are down in the scrotum is to make them a little bit cooler than the rest of your body. It's just how that's the environment they like to be in. So you have an artery taking warm blood to the testis, and this complex of veins that kind of surround it very closely, and that has cooler blood going back to the body. So it actually kind of acts as a heat sink to make the blood going to the testis a little bit cooler, again helping it stay cooler. So there's thought that not only do you have a little bit of a hotter testis, a warmer testis, if you have a varicocele, but also other theories that you have increased reactive oxygen species, metabolites, kind of breakdown from just the testis functioning can accumulate in that testis and not let it work as well as we'd like it to. Another common thing that we see in infertility or subfertile guys are obstruction or blockages. And this can happen anywhere along the tract, from the epididymis all the way to the urethra. So if you have a blockage there, obviously it's going to prevent sperm from coming out. Multiple causes anywhere. Obviously the most common is vasectomy. Trauma, infections can cause blockages. Surgeries can cause blockages. And then also you can have congenital issues where, for example, some guys are missing a vas. They just don't have one, so obviously the sperm can't get anywhere. These are all important because these are places that we can intervene to hopefully help with fertility and conception. So not only do you kind of need to have the physical parts, but you also need to have hormones, and also genetics play a part as well. Excuse me. So in terms of hormones, we have a pretty specific axis that allows the testis to function. We call it the HPG axis. So you have the hypothalamus up here, the anterior pituitary, and then the G is the gonad or the testis. And this is basically the signal that's pushed out for the testes to function. So the hypothalamus puts out GnRH, and I'll try not to get too technical, to the pituitary, and then that spits out LH and FSH. Those are the two things that the pituitary gland sends out to say, hey, testicle, work, do your job. I tell people it's like stepping on the gas pedal. If you don't have that signal right here, the testes aren't going to function. They don't get the message from the brain saying, hey, either 1, make testosterone, or 2, make sperm. Potential influences on this are genetics, brain tumors, obesity can affect hormones, lifestyle, and then also there's a question of whether kind of environmental exposures can affect this as well. You also have a feedback loop, which is important, where it's not just an on button. You want to regulate kind of how hard the testis is working, and also hormone levels. So testosterone and other things like estrogen loop back to the hypothalamus and the pituitary to kind of regulate things, to keep things from kind of, let's say, overheating. Genetics also play an issue. Pretty complex. We're still working on kind of the basics of what genes do you need specifically to be fertile. And there's a lot of work going on in this area, but not quite there in terms of great detail. We do know that on the Y chromosome specifically, there are a set of genes that you have to make sperm. So for some gentlemen, that's something that we can check. If you have no or very, very low levels of sperm, that's something we'll check, because potentially you could pass that on. So with anatomy, kind of the hormone or HPG axis, and genetics, those are kind of the 3 silos that you need, all kind of getting checked off to be fertile and hopefully have a kid. So from there, kind of who should be screened. So these are kind of the 3 criteria or guidelines for who we suggest comes in for a workup. So any guy who's been trying to conceive for a year or more, kind of, and this is intentional, trying to conceive, not on contraceptives, you pull the goalie, they should come in, and their partner should as well. Again, it's a 2-person issue. And then there's some more specific caveats. So if your partner is greater than 35 years, then we say we can kind of drop that down to 6 months. And if they're greater or equal to 40 years, then kind of come in as soon as you guys are trying, because at that point, time's important. And also any couples with a known potential cause of fertility should kind of come in at any time. So if you know that you have a varicocele, but you're having issues conceiving, then kind of the whole timeline goes out the window. In terms of this graph, so this is just kind of the data for why they came up with these numbers. So on this axis is maternal age, or the age of the woman, and this is pregnancy rates per cycle, or basically per month. Blue line is basically normal fertility. Orange line is basically a mild male factor, so where a lot of our patients in the infertility clinic will come in. And this lower line is women who have other anatomic issues and major concerns that drop their fertility chance. But at 30, for kind of your average couple, about 20%, every month you have a 20% chance of getting pregnant. But you notice it stays kind of steady till you hit 35, and then you start to notice a pretty an inflection point and a drop in fertility. This never goes to zero, though. So that's why you have the stories in the news of the 55-year-old lady who got pregnant. It can happen, just the odds are exceedingly low. So this data kind of helps us to dictate and also kind of customize treatment plans. If you're 30, time's not an issue, then we can kind of work through things and take our time, think about it without a lot of stress. If we're 40, we have to start thinking about how do we expedite things, how do we give you the best chance of pregnancy. So what is a fertility workup? What can you expect? So kind of at its most basic, we do 2 semen analyses. And we'll get to kind of what that involves in just a second, but that gives us an idea of exactly what's in the ejaculate. We need 2 because we know that men's semen analyses vary pretty widely. They can never do this study now, but back in the 60s, they took a guy in prison. I believe he was incarcerated. They had him give a sample for basically 1 week for a year, and they just looked at what was in there. And while he held kind of in a steady range for most of it, there were days where he had a ton of sperm and there were days where he had 0. So that's why a single data point doesn't tell us much. But the semen analysis is kind of our basic starting point for a fertility workup. And it's important that if you get this done, you go to a lab that does this often, who's accredited, because there are specific ways in which the sample has to be run. And while over-the-counter semen analyses can be helpful in terms of do you see sperm or not, typically they don't give the detail that's kind of really required to kind of get down to what's going on. From there, should we find any issues with the semen analysis, we look at hormones. So again, that HPG axis, so testosterone, FSH, LH, we're all kind of in that diagram that we showed earlier. And sometimes we add on estradiol or estrogen, because that can affect things as well. And then sometimes prolactin, which is another hormone in that axis. If your counts are 0 or very, very low, then we'll look at the genetics. So one of those is a karyotype, which you can see here. So basically, this is a look at your genes. Each of these is a chromosome. And it's looking for basically to make sure that the overall architecture, things are where they ought to be. So think of it like a map. If you're looking at the US, it's not going to show you individual genes or roads on a map. But if Florida and Texas swapped, you'd know that it happened. Specifically here, guys have an X and a Y chromosome. This guy has an extra X chromosome, so that's a genetic disorder, Klinefelters, that we see often in the infertility world. From there, obviously, everybody should get a focus exam to make sure they don't have things like varicoceles or other concerns. And occasionally we'll do imaging, which is typically ultrasounds of either the scrotum or the prostate, which can be transrectal. So there are a few other super detailed tests that we can do, but they're in pretty specific circumstances. But these are kind of the core of our workup. Jumping to that semen analysis. So this is kind of what you can expect to see when you get one. And we'll kind of roll through all the different areas. So the first thing we look at is sperm volume, which actually should be semen volume. Semen's what comes out, sperm are the actual cells. So semen volume, you want to see at least 1.5 milliliters. If it's lower than that consistently, excuse me, then we start thinking or have to think about whether there might be a blockage somewhere. Or just things aren't getting where they need to be. From there, we look at concentration or sperm count. I care more about sperm count because that's just the raw numbers. How many sperm did they see? Concentration pulls in volume, which is just kind of a modifying factor. But for sperm count, we want to see at least 40 million sperm. Okay. And then we look at motility. You want to see around 40% or more of your sperm moving. If they can't move or swim, they're not going to get anywhere, right? So that's very important. Morphology is what does the sperm look like. So this is a sperm. You have a little acrosome at the tip, like a little hat. This helps the sperm and the egg kind of interact and start that binding. You have the head, which is where the kind of genetic material is, mitochondria, and the tail. This is what actually moves to help it swim and propel itself. So morphology just tells us, what do the sperm look like? Do they look normal? So if you look, to be normal, only 4% or more of your sperm have to fit the lab criteria. Luckily, though, I don't care about this. This has no bearing on pregnancy rates, so I don't look at morphology, and data would suggest that there's really trying to change that doesn't change outcome. So I kind of take it off the table. There also isn't much you can do for morphology in an isolated. If it's just morphology, there isn't much that you can do to change that. DNA fragmentation is a test we can do in very specific circumstances, which you won't get into right now. But overall, the main things we look at are volume, count, and motility. So all that leads up to possible interventions, and that kind of boils down to two areas. One being surgical interventions, so either we're fixing an obstruction somewhere, we're going directly in to just retrieve sperm, or we want to improve that testicular microenvironment so it can just function better. The other option is medical management, and that's typically just to optimize testicular function. So everything we do kind of falls under those two categories. So in terms of medical management, so that kind of goes back to hormones and that HPG axis. And there are kind of two categories that we work with in terms of options of intervention. So one option are these are SERMs, or selective estrogen receptor modulators, long words to say that they help block this feedback here. These red signs, meds like clomiphene or Clomid help to block this, which means that this green sign goes up, basically like pressing on the gas pedal harder. And an increased signal to the testis to work. You see that on hormone panels has increased testosterone. Clomid specifically has pretty low potential side effects, kind of water and weight gain. Some guys get rashes, but if you stop the med, it all goes away. The other option is an aromatase inhibitor, like Arimidex is one that we use. So testosterone, and you can see it here, gets converted by fat tissue, by lipid, into estrogen. So if you have a lot of lipid or fat, it can actually skew that testosterone to estrogen ratio, which then will feed back. Estrogen really likes to inhibit this loop, and that can decrease your testosterone in this kind of cycle as well. So that's another option to kind of play with this loop. Kind of side effects or risks for this, you get gynecomastia or breast growth, weight gain. We use a really low dose, but there's a theoretical risk of blood clots, and it can also affect bone density. Kind of importantly, we talked a little bit earlier about how it takes 74 days, give or take, or about a little less than 3 months to make sperm. Any changes that you make medically, it takes that amount of time to see, because everything else is already in process. So there's no quick fix in terms of sperm production if you go the hormone route. Which, if you're 40, those are all little things that kind of tie in. You're trying to kind of customize or plan with a couple or patients. And then we get to surgical interventions. So kind of the three main areas for that are vasectomy reversals. Varicocelectomies are dealing with those dilated veins going to the testicle, and also surgical sperm retrieval. We won't get into it today, but for folks with spinal cord injuries, we do have other ways of either helping guys ejaculate or getting sperm. So that's a little side area. But we do have the ability to help guys with that, which is awesome. So these surgeries, we'll start with the varicocelectomy. So as we said, the varicoceles are those dilated veins that go to the testicle, making it just not as nice of an environment for it to work in. So our goal is to basically ligate those so they go away. So for the surgery, and all this is done under a microscope, basically, it's like 2-inch square little area. We make a little incision here, kind of right above the penis. And what we're able to do is bring the cord or the structures going to the testicle up out of the skin. The reason we go here is because there's no muscle layer there. So it makes your, recovery easier than if we went through muscles. You would feel it a lot more. So what we do, as you can see here, is we ligate or cut the veins so that things have to reroute, but we leave the artery, nerves, lymphatics, or the little tubes that help kind of drain fluid away from the area, and the vas deferens alone. And we do this under the microscope so we can get every little last vein without hurting, obviously, the important structures. Kind of logistically, it's an outpatient surgery. And again, its goal is to optimize that testicular microenvironment, thus improving sperm count and motility. If you look at data, and it kind of depends on the severity of the varicocele, the grade of it, you can see improvements in sperm count anywhere from 30 to 50%. Varicoceles are graded 1 to 3. The higher grade varicocele is going to see more of a response typically from surgery. Kind of the other category, vasectomy reversals. So obviously when you get a vasectomy, they snip here and here, or kind of relatively there. The goal is basically to put things back in the continuity so you can achieve pregnancy kind of the natural way. And so there are technically 2 ways of doing it, and that will kind of dictate your outcomes. If you go vas to vas, your outcomes are up to 95% of getting sperm back in the ejaculate. If it's vas to epididymis, it's more like 60%. We don't quote pregnancy rates because it's a 2-person issue and it gets kind of complicated in terms of statistics. But typically pregnancy rates mirror about half of that. So if you can go vas to vas on both sides, you expect about 45-50% pregnancy rate. If it's vas to epididymis on both sides, it's more like 25-30% for pregnancy rates. Recovery is going to be a little more involved than just your typical vasectomy because the incision is larger. So it's not as, you'll be up on your feet, but not as quickly. Importantly, it doesn't work immediately. Things have to heal. It can take anywhere from six months to a year to see sperm back in the ejaculate, and it doesn't fix any other fertility concerns. So if you have other issues, let's say hormone or whatnot or genetic, it's not going to fix that. And just as a caveat, about 6% of guys who have vasectomies will come back and at least ask about a reversal. From there, we talk about sperm retrieval. So that's going straight to the testis or the epididymis to get sperm. Multiple ways of doing this. Typically, we do this for blockages or when guys have 0 sperm seen on a semen analysis. So this is just kind of a depiction of what typically the options are. So orange is the epididymis, yellow is the testicle. Sometimes we can just stick a needle in the epididymis or the testicle to get sperm. Sometimes we'll just take a chunk of the testicle out. But sometimes, especially if they have 0 sperm on a semen analysis, we do a surgery called a microtesty, or under a microscope. We basically open the testicle up and we basically look for better looking tubules with the hopes of having sperm in them. These are kind of wispy, and then these are nice and thick, so this is where the sperm tends to be. The important kind of distinctions between these, some you can do in the clinic. This obviously needs to be done in the operating room. Whenever you do this, there's no guarantee that you're going to get sperm, so it's kind of weighing risk and benefit. And regardless of even if you're successful, just the amount of sperm you're getting is typically not very high. It's not a normal ejaculate, so it requires that the female partner does IVF. So you can't conceive naturally with a sperm retrieval. which is a pretty important consideration. Kind of going to, as I said, the modern concerns with fertility. There's been gaining kind of publicity and concern that sperm counts are falling, and this is specifically in Western countries. So back in 2017, there was a large study that reported an almost 60% drop in sperm counts between 1973 and 2011. And I made it in Newsweek. There was a whole book put out on it, articles in The Guardian. It's really kind of garnered some real attention. And there's some thoughts behind it, whether it be environmental factors, we're just not as healthy these days, or we live in kind of a demasculinized world. All these things might be contributing to this drop in sperm counts. But obviously, when somebody puts out a hypothesis, and this is called the sperm count decline hypothesis, there's going to be obviously some people on the other side of the fence. So there's also some thought that if you look at the data, they're trying to kind of compare apples to oranges, different populations to different populations, and it gets rather complicated. So there's some thought that sperm count is actually just a variable in terms of our health and our wellness. And it's to be expected that you're going to see ups and downs, as we talked about earlier. They also kind of criticize, or I shouldn't say criticize, but talk about how this large meta-regression, while it's very well done for a regression analysis, isn't detailed enough to give you a great picture of exactly what's going on. So there's still a lot of debate about this, but there's some camps that think that there's a decline in our sperm counts, and that's affecting our ability as a society or whatnot for people to get pregnant. So lots of debate, very important, but there's no kind of definitive answer yet. There's also some data that, especially if you all have heard in the news recently, kind of PFAs and forever chemicals are having pretty profound impacts on our bodies. They're thought to kind of interrupt either the hormone axis or the testis itself, so that it doesn't function as well. And while there's some pretty good data on this, there's a lot more work that needs to be done to figure out exactly what's going on. Sorry if you can hear the helicopter, it's coming in. But an area of concern, but how we approach it and deal with it will be kind of need to be figured out, because PFAs are honestly in a lot of the stuff we use, so it's hard to avoid it if you're out and about. But I assume over the next few years, there'll be more data coming out about this. So importantly, kind of what does every guy want to know? What can I do to optimize my fertility? It's pretty basic. So anything that's heart healthy is testis healthy. So kind of Mediterranean diet has been shown to improve sperm semen parameters. There's one study that showed that this stated specifically high intensity interval training led to increased semen parameters, but basically being active, eating healthy are all ways that you can optimize your testis function. I recommend all my guys take a men's multivitamin with antioxidants, like coenzyme Q10 or CoQ10 as a good thing to do. Mixed data certainly won't hurt, and there's some data showing that it will help. You don't need to specifically go out and buy like a fertility vitamin. Just any men's multivitamin with antioxidants will do. Honestly, they just jack the price up on you because it says fertility on it. Avoid smoking of any type. Tobacco, marijuana, all of those have been shown to decrease sperm count and motility. Alcohol in moderation. Again, kind of the whole anything that's heart healthy is testis healthy. It takes a lot of alcohol to really shut things down in terms of testis function. Basically enough to start hurting your hormone axis. And it's easy to say, but the less stressed you are, the better things will go. Stress can kind of ramp up cortisol and other hormones, which aren't great, and who wants to be stressed? Easy for the physician to say when they're not in the position of trying to conceive and it's been 2 or 3 years, but as much as you can, limiting stress is helpful. I've had some guys go to fertility acupuncturists, yoga, whatever, anything that helps you to kind of get through it and limit that stress. Super importantly, do not take testosterone or testosterone supplements. Basically, if you take them, again, that HPG axis, if you take testosterone, your body's going to think, oh, we're set, we're good, and effectively the testis will shut itself down because something else is doing its job. A lot of testosterone supplements, they're not FDA regulated, so you don't know exactly what's in them. So they could be affecting things as well, even if it's not specifically testosterone. So I tell my guys better to err on the side of caution than to take them. If you do have low testosterone, there are ways we can manage it, but these specifically can hurt you, and obviously we don't want to do that. If you do take testosterone, and this happens every now and then, there's a chance that, while uncommon, when that axis shuts down, there's actually a chance it doesn't come back, even if we try to jumpstart it with medicines. So things to think about if you have low testosterone. So that's it. Any questions?
Thank you so much for that really informative presentation. We now will open the floor to any questions. I do have a few that were submitted beforehand that we'll start with. The first is, if I have my vasectomy reversed, will that affect my fertility?
So that's the hoped for and expected goal. So obviously, if we have a reversal, we want things to be back in continuity. You want that blockage to go away. One of the best letters you get is when you reverse a vasectomy, and then 12 months later, somebody sends you a kid on a postcard. So yeah, that's the hope, is that it will affect your fertility in a good way.
Absolutely. Are there any natural ways to boost fertility for men?
So again, this kind of goes back to, I guess, the last slide. So anything that's heart healthy or is testis healthy, multivitamin with coenzyme Q10. More recently, I've had some guys coming in kind of taking more of an herbal approach. There's no great data for it, but I haven't told them to stop taking it. It hasn't really affected their hormones from what I've seen. But again, kind of with the caveat that we don't have a lot of great data on to say yay or nay.
Right. Okay. Can alcohol consumption affect semen count or quality?
Yep. So again, kind of went through that, but I get this question all the time. It takes a lot of booze for it to affect your count or quality. Basically, once it starts affecting your overall health, is when it may affect your fertility. You certainly don't need to go like cold turkey or stop drinking altogether. But if you kind of stick to the guidelines, you should be fine. Okay.
Can testosterone supplements positively affect chances of conceiving?
Yep. So again, seen pretty often. So the thing with supplements is you don't always know exactly what's in them, and there might not be data in terms of how it's going to affect things. So again, I always kind of tell my guys to err on the side of caution if you're struggling to conceive. And if you are concerned about your testosterone levels, that's something we can deal with in a way that kind of takes any concerns about fertility off the table.
Gotcha. And I have one more here. Can chemotherapy and radiation permanently affect sperm count? Are there options men should consider before this type of treatment?
Yep. So very, very, very good question. We call this oncofertility, or kind of cancer fertility. So yes and yes. So chemotherapy and radiation can definitely permanently affect sperm count, but with the caveat that it depends on the chemo regimen, duration, kind of age of when you had it. All those things affect whether chemotherapy is going to affect you. It's guideline standard. You shouldn't try and conceive while you're having chemo treatments, but after you get out of a certain time frame, then it's reasonable to start trying to conceive. Radiation, kind of the same thing. What matters is where did you get the radiation to? If it's away from your testis and not at your pituitary gland, then it will affect you less, and also the amount of radiation. But But yes, there's always a potential that these things can permanently affect your sperm count. If you know that you are going to need treatment, then kind of the best thing to do is to bank. Basically give a sample, it's frozen, and then after treatment, kind of see where things land. If things recover, great. Get rid of it, you're good to go. But if things don't recover as you would have wanted, then you had something in terms of backup. And I tell guys, if you can, better to do it, because you don't want to kind of wish you had later when you don't have fantastic sperm production. So banking's very easy, and it's a good backup. And I recommend that all of our cancer patients, if they're interested in fertility in the future, at least think about it.
Great answer. Thank you for that. I did have one more come in here. After a kidney transplant, currently taking testosterone, do you think the sperm count would improve?
So if your testosterone is a really good contraceptive, actually. So if you're trying to conceive right now, then your counts might be suppressed, even to the point of being zero. Part of that depends on how much testosterone you're taking and the route that you're taking it. So if you're taking injections, that actually gives you really high swings and dips in testosterone, but those high swings can really tell your pituitary gland to shut down. That being said, if you come off, there's a good chance that your sperm count will improve. A kidney transplant in and of itself shouldn't affect your ability to conceive. Yeah, so all good on that front.
Well, thank you. I think that's all the questions that have come in. It was such a pleasure having you here with us and to have this discussion. We know that these reproductive concerns are not uncommon, and this hopefully provided some more information and hope for couples that want to conceive that are having trouble. Thank you for reviewing the various treatment options and also for reviewing some of the advances in reproductive medicine. For more information about our urology team here at VCU Health or about men's reproductive health, you can visit vcuhealth.org, or you can also follow VCU Health on Facebook at VCU Health. Thank you everyone for joining us today, and have a great night.
Thank you.